Autoimmune diseases involve both the humoral and cell-mediated immune responses that become directed toward self-antigens. We can say that they're caused by a loss of self-tolerance. Intrinsic in our immune system are several mechanisms that are built in to help prevent attacking the self, but sometimes these mechanisms of developing self-tolerance break down, and so the immune system sees portions of self, thinks they are foreign, and need to be gotten rid of, and so they go into action. These autoimmune diseases can be systemic or organ specific. We'll look at several of each, and they can cause significant tissue and organ damage. Normally, with the appropriate tolerance mechanisms that we have, we shouldn't develop autoimmune disorders. We've got two categories of developing tolerance. One is referred to as central tolerance, which is what happens in the bone marrow and the thymus. You'll remember that in the thymus, one of the processes that T cells go through is negative selection. If you don't remember that, it's time to go back and review that because that's an important concept. The other thing that happens in the bone marrow, where the B cells are formed and mature, any that are found to be self-reacted are either gotten rid of or changed in such a fashion that they are no longer self-reactive. The other aspect to this is referred to as peripheral tolerance, which occurs in the lymph nodes and the spleen. The T cells should be rendered ineffective, in a term that's used as anergy, and anergy just means they're not working. Okay, so if they're not outright, killed and removed, apparently they hang around, but they don't do anything because they don't do their job correctly, so they're kind of just shut down. The B cells can be rendered anergic or killed by apoptosis. However, with both of these processes, the ones that happen in the central system and the ones that happen out in the periphery, sometimes those self-reactive guys make it through both layers and end up circulating in the periphery. This chart from your textbook does a nice job of explaining this. Basically, we have T cells on one side, B cells on the other. Up here, we have what happens with T cells in the thymus, whereby if they're, negative selection process, if they're self-reactive, they're removed via apoptosis. Some of them turn into T regulatory cells, which play a role later in helping inhibit the autoreactive cells. Over here on the B cell side, the B cells that are self-reactive are kind of shut down. They just quit functioning, or they get edited and made to be not self-reactive. Then some of them escape. They make it through these processes, and then they come down here and they're out in the periphery. The T cells, we said, are inhibited. They may be forced to undergo apoptosis. The B cells as well may be subject to anergy, stop doing the bad things that they are doing or undergoing apoptosis. And then we have these few down here, which unfortunately make it through both sets of processes and end up circulating and having the ability to go against self-antigens. Causes of autoimmune disease can be either genetic or environmental or combinations of both. We do know that autoimmune diseases in general are more prevalent among family members of someone with an autoimmune disease. So let's say within your family, dad and grandma have autoimmune disease. Well, you are much more likely to have an autoimmune disease as well. We know that certain MHC alleles are associated with autoimmune disorders, and we know that There are in above, over and above the MHC genes, there's other genes that are associated with certain disorders. Environmental factors can include things like exposure to toxins or certain foods or certain drugs. In certain areas of the body, we have what are known as cryptic antigens. These are antigens that normally the immune system doesn't see. They're hidden away, hence the term cryptic. However, if there's injury to those organs or sometimes surgical manipulation, those hidden antigens are released, and then the immune system sees them and goes about mounting an attack of them. So some examples are antigens within the eye. The testicles themselves are contain cryptic antigens, and then more specifically the spermatozoa. So surgery and injury can cause a release of these, and suddenly the immune system sees them and mounts an immune response. Epigenetics is a term referring to DNA modifications that occur in the body that aren't part of the germ cell. In other words, all cells of the body have not suffered this mutation, but rather this is a mutation in the DNA that can occur in a specific cell type in an individual. And sometimes these genetic modifications make certain self-antigens that the body has tolerance to, but a little bit of change in the genetics makes a little bit of change in those antigens, and suddenly they're immunogenic and may stimulate autoimmune disease. This may occur in diseases such as rheumatoid arthritis and multiple sclerosis. There are several mechanisms by which microbes can induce autoimmune disease. One is known as molecular mimicry. Some bacteria and viruses possess antigens that are really similar to human antigens, so that when they are in the body causing infection, they may stimulate autoimmune reaction. A classic example of this is Streptococcus pyogenes. This is the organism that causes strep throat. Some of its antigens are very, very similar to heart antigens. And so certain people, especially if they have long-term strep infections that aren't treated rapidly or adequately, they can become prone to developing rheumatic fever after the fact because they have developed these antibodies to the bacterial antigens that unfortunately cross-react with heart muscle. The bystander effect associated with some pathogens, they initiate the inflammatory response that activates the T cells, gets them revved up, and some of these T cells end up with self-specificity. Superantigens are proteins produced by some microbes that have the ability to bind to class II MHC molecules and T cell receptors regardless of specificity. They just kind of get these, get the whole system really supercharged, if you will, and they can activate large numbers of T cells with many different specificities, some of which may be to self-antigens. An example of this is infection with certain strains of Staphylococcus aureus produce enterotoxins, which can lead to the development of toxic shock syndrome. And lastly, and this is extremely current, and I'm sure you've seen things alluding to this in the paper, online, what have you. We're really heavily studying our gut flora. We know that our gut, as in our alimentary canal, specifically our large intestine, is packed with many species of organisms. And we're finding that if a given individual lacks certain organisms, or on the flip side, sometimes has certain organisms, then these are associated with certain pathologies. And so the speculation is that perhaps there are some gut organisms that um, can lead to the development of autoimmune disorders. Um, Watch for this. There's going to be big developments in the years to come. I think the jury is still out on some of the theories and the suppositions, but they're working on it. So when we put it all together, and we end up with this individual who has some sort of autoimmune disease, or maybe more than one type of autoimmune disease, things that could have led up to that include their sex. We know that females are far more likely to develop most autoimmune illnesses. There's a couple of exceptions, but by and large, far more females have autoimmune illness. So could be related somehow to the presence of those female hormones. We talked about microbes that can induce autoimmune situations due to molecular mimicry, super antigens, etc. These epigenetic factors, these things that can cause changes in the DNA of cells in certain parts of the body that then the immune system recognizes. Um, we actually started with the fact that the individual himself, actually, because of the genetic makeup, may be from the get-go more prone to developing autoimmune disorder. And then lastly, of course, what plays into this is this loss of tolerance, that somehow we get this activation of these self-reactive T and B cells, and so autoimmune response to self-antigens. At this point in time, we've identified in excess of 100 autoimmune diseases. They include diseases that are systemic and those that are organ specific. So we're going to look a little bit at SLE, which is short for systemic lupus erythematosus, aka lupus to most individuals, rheumatoid arthritis. There's an interesting one that's not as common, but it's called granulomatous polyangiitis, thought to follow certain infections where there's widespread inflammation, and that can affect anywhere in the body. In terms of organ-specific autoimmune diseases, we're going to look at a few of those as well, which include a couple of thyroid diseases, type 1 diabetes, celiac disease, autoimmune liver diseases, multiple sclerosis, and a couple of other ones. One of the first autoimmune diseases that was characterized and studied, many people know as lupus. Lupus is short for systemic lupus erythematosus, SLE for short. In the name, systemic, that gives you the clue that this is not organ specific, but rather it affects the entire body. The lupus portion of the name comes from wolf. The scientific name of a wolf is Canis lupus. And to early people studying the disorder, the face of the wolf, or I should say the face of patients with lupus, they felt looked somewhat wolf-like. It's a stretch. In a minute, we'll make a little better correlation of why they thought wolf when they saw patients with this disorder. So it's a chronic systemic inflammatory disease, affects multiple organ systems. Patients develop numerous autoantibodies to cell nuclear components. As we look at this a little closer, we'll learn that it could be several different portions of the cell nucleus. One of the antibodies to one of the portions of the nucleus is to double-stranded DNA. People with these autoantibodies develop immune complexes. This triggers complement activation, which of course then helps accentuate the chemotaxis of the neutrophils and the inflammatory response. The clinical symptoms of lupus are far ranging because it is systemic, and basically any system of the body can be affected. The classic symptom that you want to associate with lupus is this butterfly rash. If you're doing a case study or taking a test or anything, and a butterfly rash is mentioned, chances are they're trying to point you towards lupus. And this is the butterfly rash. You know, this one is very prominent. They're not always quite this distinctive and obvious. But as we go back and look at our picture of Mr. Wolf, this is what people were thinking when they named the illness. I think it's a bit of stretch of the imagination, but you know, if you're an early person researching something new, you get to name it whatever you want. And so we have lupus. Another hallmark uh, symptom of lupus is sun sensitivity. You know, people that formerly were able to go out and enjoy an afternoon in the summer sun, suddenly that is very uncomfortable for them and actually can, you know, cause them to feel sick. Um, and also exposure to the sun often accentuates and brings out the butterfly rash. And from there, we go to, you know, a plethora of signs and symptoms depending on, you know, whether it's the joints that are being involved primarily at a given time, or the kidneys, or, you know, the blood cell production, or what have you. Individuals that I have known with lupus tend to go through flare-ups and then remissions. And one individual I'm thinking of in particular, she would be relatively healthy for a number of months or a few years, and then she would have a flare-up and end up in the hospital for a period of time. So it's definitely not a minor illness. A person can live with lupus for quite some long time. However, the quality of their life is definitely adversely affected, and ultimately, the consequences of this disorder can be lethal. There's a couple of good diagnostic tests to help the physician make the initial diagnosis of lupus. And then there are a few tests that are useful to the clinician as the patient undergoes treatment, tests that can help assess whether the treatment is being effective or not. Back in the day, a lab test that was used to help diagnose lupus was called an LE-PrEP. LE-PrEPs, I don't think, are still done anywhere. I know back in the day when an order came in for an LE-PrEP, I was not a happy camper if I was working in hematology. They were a pain in the neck, to be blunt. They were cumbersome. They were not particularly easy to read, at least in my opinion. The good news, for me anyway, was that they became outdated, and they weren't all that great of a test in the first place. But we did figure out a better way to do this. Because we know these individuals develop antibodies to nuclear components, one of the tests that is now run is referred to as an ANA test, anti-nuclear antibody test. Typically, a doc orders the test to help him decide if the patient has lupus. And if the initial test is positive, then we run titers to give him an idea of how high the titer is. I will say, and you need to understand this, that this is not a very specific test. I myself have had a couple of positive ANAs in my lifetime when I have been ill, and the doctor was, you know, running lab tests to figure out what was going on, and lo and behold, I had a positive ANA. But I don't seem to have lupus. This is one of those things that definitely not a great diagnostic tool. However, it's good. It's good enough to use. And besides the positive result, the clinician is very interested in how high the titer higher titer is more suggestive of lupus than a low titer. On the flip side of things, there are people with lupus who may have negative ANAs as well. So both sensitivity and specificity leave something to be desired in this test methodology, but it's good enough to use, at least till we figure out something better. C-reactive protein. CRP is one of the acute inflammatory um, chemicals that when inflammation is occurring anywhere in the body, the CRP is elevated in the blood. It's not a good diagnostic test for SLE because any cause of inflammation will lead to a positive CRP. However, a person under treatment, the CRP can be used by the doc to help evaluate whether the treatment he is using is being effective or not. And also, if he suspects a flare-up may be coming or in progress or whatnot, can order CRP to confirm that. Erythrocyte sedimentation rate, ESR or SED rate. An elevated SED rate is also an indication of inflammation in the body. So again, it's not good for diagnosis, but it can be helpful to monitor treatment efficacy and the presence of a flare-up. And also, again, for monitoring purposes, we can quantitate the patient's complement in their blood because during active flare-ups, the complement levels can go down. Why would they go down? Well, they're being used up, so to speak, because of the inflammation. Complement is being activated, and so circulating C3 tends to diminish. As we've established, these ANAs are antibodies directed against antigens in the cell nucleus, and they are present in over 95% of lupus patients. Antibodies include anti-double-stranded DNA. This is the one that is considered specific for lupus. Anti-single-stranded DNA, antihistones and nucleosomes, antibodies to centromere or nucleolar components. And then lastly, there's a group of antibodies that are called anti-ENA. Now, the ENA stands for extractable nuclear antigens, and that's all well and good because that's originally what was included in this group. However, as things progressed, what's in there now is besides the antigens to nuclear components, there's also some cytoplasmic components. So it's a little bit of a misnomer, but that's okay. The name stuck. So this anti-ENA panel is sometimes ordered to screen for connective tissue disorders such as lupus and Sjogren's syndrome and some other ones. So the anti-ENA is a panel, and the others are a relatively specific diagnostic tests. The fluorescent ANA is pretty simple and straightforward. We start with a microscope slide that has cells on it. We're going to add patient serum. Presumably, the patient has antibodies to some component of the nuclei of those cells. And so we give that reaction time to occur, then wash the slide off, and then add antibodies to the human antibodies. Only these last antibodies are tagged with a fluorescent tag. And then when we read them, we're looking for different patterns indicating what part of the cell nucleus the patient's antibody are specific for. These are not particularly easy to read. They look pretty easy here in a drawing. But in real life, they're a little trickier, and this requires a bit of practice to get good at them. I'm going to have you go to the MTS website this week and complete a tutorial on ANAs. I don't expect you to become experts after viewing the tutorial, but read through it and then take the test enough times to get yourself 100 for the assignment, and it'll give you a pretty good idea of what these are all about. As far as what kind of cells are on those slides when we start, somebody somewhere along the line figured out that we can use an organism called Crithidia luciliae. This is a parasitic protozoan organism. I believe it parasitizes houseflies, so who knows how they, what prompted them to use this. But they found out that these organisms have an organelle, a kinetoplast, which is rich in double-stranded DNA. So using these cells is a really good way when we're looking specifically for anti-double-stranded DNA, which is diagnostic for lupus. And so these cells are very often used in those test kits. We can test for ENA by using the Autoimmunity test. You remember Autoimmunity is the double diffusion test. And so what we do is put a suspension of this ENA, these are the antigens, in that grouping we mentioned earlier. And then we add specific antibodies here, smooth muscle antibody and RNP antibody. And then we add patient and allow this thing to incubate. And then we look at these lines of identity. So there's a line of identity here between the anti-smooth muscle antibody and the patient. And so we can safely determine that the patient has antibody to smooth muscle. And then down here, same patient, but we had the anti-RNP antibody. We've got a spur. So there's some relationship between the two, but it is likely that they don't have the anti-RNP antibody. And then patient B doesn't have either one. There is an antibody known as antiphospholipid antibody, which is present in about 60% of lupus patients. Sometimes it's called the lupus anticoagulant, and people with lupus do tend to have a prolonged APTT and pro time. This antibody is associated with deep vein and arterial thrombosis, an increased risk of pregnancy loss, and can be significant in trying to track down false positive results in non-treponemal tests for syphilis. Leaving lupus now, we'll take a look at rheumatoid arthritis, or RA. Rheumatoid arthritis is a chronic arthritis of the peripheral joints and can progress to joint deformity and disability. About a quarter of these patients have osteoporosis. Some RA patients also develop subcutaneous nodules, pericarditis, interstitial lung disease, and vasculitis. Rheumatoid arthritis is another systemic autoimmune disease. Even though it has arthritis in the name, and you might be tempted to think it's just a joint disease, it surely is systemic. In rheumatoid arthritis, the chronic inflammation destroys bone and cartilage. There's a role to be played in the process by tissue necrosis alpha, one of the cytokines that we talked about in the past. These people have overly active osteoclasts. You remember that the osteoclasts are the bone cells that absorb the bone. So in the case of people with this disease, bone absorption is exceeding new bone formation, and so of course that's a problem. The autoantibodies that these individuals have combined with antigens form immune complexes. So this is indeed an immune complex disease. Treatment, NSAIDs, the anti-inflammatory drugs, starting off with over-the-counter things like Aleve and Motrin and Advil. Over time, they tend to not be strong enough for most patients, and they need to progress to stronger prescribed anti-inflammatories. Um, there's anti-rheumatic drugs, and also there's drugs that target that tissue necrosis factor alpha. One of the first screening tests for rheumatoid arthritis was the test looking for rheumatoid factor. And this rheumatoid factor is actually an autoantibody that reacts with the Fc portion of IgG antibodies. It is found in about 80% of the patients with RA. So a positive RF suggests the patient may have rheumatoid arthritis. However, it is not specific for RA. So a lot of inflammatory disorders will give us a positive RA, and those patients may not have rheumatoid arthritis. There's a more specific test available now called the anti-CCP. This one is specific for RA. This is an antibody directed against cyclic citrullinated peptide. And so where this is available, this is, and the doctor wants to confirm the diagnosis of RA, this would be a good choice. ANAs are often positive in patients with rheumatoid arthritis. And of course, we've learned that people with other autoimmune inflammatory diseases also demonstrate positive ANA. So just referring back to that test, it's a good test, but it's not very specific. And then the doc may want to monitor patients with RA with SED rates, CRP, complement levels, generally to monitor the efficacy of treatment and the disease progression. There's several autoimmune thyroid diseases, or AITDS. We're going to look at a couple of them. You may remember from physiology that the feedback loops for regulating thyroid hormone are relatively complex. And so, in my mind, whenever a system is complex, it means a lot could go wrong. And so there are different aspects of thyroid disorders, implying different things happen. But what I want you to focus in on right now is that, it is highly regulated by this endocrine feedback loop. And because of that, thyroid disorders can lead to either increased production of thyroid hormones or decreased production of thyroid hormones. Hashimoto's thyroiditis is caused by the immune destruction of the thyroid gland, which leads to hypothyroidism. Symptoms include fatigue, dry skin, weight gain, brittle hair, formation of a goiter, or an enlarged thyroid. In the lab, we might see normal TSH levels or high TSH levels as the tissues respond to the lack or the diminished amount of thyroid hormones. They're sending the message, hey, tell the thyroid to send more. And so those TSH levels go up. We would see a low amount of T4 in the blood. And we also could check for antibodies to thyroid peroxide. These tend to be present in Hashimoto's, as well as antibodies to thyroglobulin. Graves' disease is an example of hyperthyroidism. The thyroid is releasing too much thyroid hormone because thyroid hormones are metabolic regulators. If there's excess thyroid hormones around, the symptoms include nervousness, they can't sit still, hyperactivity, weight loss, rapid heartbeat, goiter. Remember, that's the enlarged thyroid, but it seems like whenever the thyroid's out of whack, it enlarges and forms the goiter, and something called exophthalmos, which we'll look at in a moment. In terms of hormone levels, the TSH is going to be low. Why? Because there's too much thyroid hormone in the tissues. And so the tissues are basically saying, hey, stop, we have enough. And so that regulator hormone, the thyroid stimulating hormone, goes down in an attempt to tell this thyroid to cut back on production. And conversely, the thyroid hormone circulating in the blood is increased due to the hypersecretion of the thyroid. Now, this exophthalmos, it means the eyeballs are protruding. Buggy eye, if you will. I'm sure that's not a nice politically correct way to describe it, but it does describe it. You may know who this is. This is an old actor, comedian named Marty Feldman. He was around when I was younger, and so I would see him periodically on TV shows and whatnot. But this picture is from a movie, Young Frankenstein, which is kind of a cult hit, and so it's possible you may have seen this guy in Young Frankenstein. But anyway, he had exophthalmos, I'm assuming due to Graves' disease, and he kind of made his career on this very unusual look. And so, anyway, see if you remember this guy. But there's another one that's much more recent, which I hope you know who this is. This is the first Mrs. Bush. This is Barbara Bush. And I'll tell you a personal story. One day when her husband was in office, and of course she was the first lady, and it was a news, 6 o'clock news probably, and they were overseas somewhere and showed some footage of her and George, and she kind of turned her head, and something clicked in my mind, and I kind of said, her eyes are buggy. I wonder if she has Graves' disease. And so, anyway, sure enough, after digging around, I did find that she has Graves' disease, controlled normally by her medication. But if the medication gets out of whack, then, she would start to demonstrate a little bit of this, protruding eyeball. And eventually I was able to find one little snippet online where she said that it was a problem sometimes when they were traveling, because of course they're flying through all different time zones, and it's a busy schedule, and you don't get acclimated to that. And she would get out of whack with her thyroid medicine, and so she would sometimes start to feel the symptoms, of course, the nervousness and the rapid heartbeat, etc. And sometimes she demonstrated some of the exophthalmos. So, of course, I thought I was, something special because I diagnosed this woman from the 6 o'clock news. But anyway, it just goes to show you that we lab techs know a lot, and it's always good. It's always a good feeling when you can put things together and figure things out based on this huge knowledge base that you're amassing by working on your degree in clinical lab science. Type 1 diabetes mellitus is the type that used to be referred to as juvenile diabetes. We've been trying to get away from that name for quite a while, but sometimes you'll still hear people use the phrase, especially older people. This is an endocrine disorder, and it's characterized by hyperglycemia, or increased sugar in the blood. It's caused by the destruction of the beta cells in the pancreas. Those beta cells are the ones that produce insulin, and so as their numbers diminish, there's less insulin available, and that insulin deficiency, of course, leads to the lack of the ability to move glucose from the bloodstream into the cells and tissues. Long-term effects of type 1 diabetes mellitus: cardiovascular disease, kidney dysfunction, nerve damage, blindness, and infections. In the lab, we expect to see increased blood glucose. Even the fasting glucose is likely to be elevated unless the DM is very well controlled. The better monitor is hemoglobin A1C, because this evaluates the average glucose level for the previous several months. There's also antibodies that are detectable to GAD and IA2 and ICA. We're not going to worry too much about those, but just I'm sure you know about the increased blood glucose and probably aware of the increased A1C as well. Celiac disease affects the small intestine and some other organs. It is triggered by gluten, which is the form of protein found in wheat and some other grains. Interestingly enough, people who have certain HLA genotypes tend to be more prone to have celiac disease. It's not diagnostic, but it turns out that certain HLA-DQ alleles seem to be present in the vast majority of people that have celiac. So there's several different antibodies that can be tested for. None of them is highly specific. So first thing the doc will do, given the patient's symptoms, is usually run some of these antibodies. And if they are positive, then go in and do a tissue biopsy of the intestine. And that is makes the definitive diagnosis. Symptoms are diarrhea, abdominal pain, and bloating, sometimes extremely severe. Treatment is basically avoidance. Stay away from gluten. There are some meds that if a person inadvertently ingests gluten, some meds to calm down the symptoms a little bit as they get through an episode. Autoimmune liver diseases can lead to end-stage liver failure if they're not treated. Clinically, we would find elevated liver enzymes, fatigue, nausea and vomiting, abdominal pain, itchy skin, and jaundice, the yellowing of the skin and the mucous membranes. In autoimmune hepatitis, the hepatocytes are targeted, and there's a few autoantibodies that are typically seen. The most characteristic diagnostic antibody for autoimmune hepatitis is anti-smooth muscle antibody. In primary biliary cirrhosis, we see autoimmune destruction of the bile ducts, and this leads to backup of bile. These people typically produce antibodies to mitochondria, or AMAs, which can be used for diagnosis. Multiple sclerosis, or MS, is an autoimmune disorder that involves inflammation and destruction of the central nervous system. You'll remember that the CNS is the brain and the spinal cord. Most patients produce antibodies against the myelin, which the myelin sheath is the particular protein that wraps around the axons of nerve cells in the CNS. They form what are called plaques in the brain and the spinal cord, and these plaques cause the destruction of the myelin sheath. And what the myelin sheath on these nerve cells in the white matter, basically it's an insulator. It helps nerve signals go faster, and it also insulates from the standpoint that it keeps a particular impulse traveling on the right axon. That impulses don't kind of leak off and fire up other axons as well. So as this myelin sheath is disturbed and destroyed, depending on specifically where the plaques are, it's going to affect nerve function to those parts of the body. And this is a progressive illness. Symptoms include visual disturbances, weakness in limbs, dizziness, sensory abnormalities. As far as laboratory findings, MRI does show some lesions. Of course, that's out of our wheelhouse in the lab, but they will have increased immunoglobulins in the spinal fluid, and protein electrophoresis of the spinal fluid will show some increase in the oligoclonal bands. Myasthenia gravis, or MG, is an autoimmune disease that affects the neuromuscular junction, and it results in weak skeletal muscles. Most patients with MG have antibodies to the acetylcholine receptor, and we'll learn a little bit more about this in this week's case study, and you'll see that besides the antibodies to the acetylcholine receptor, there's some other ones that are being discovered that may be even more specific to MG itself, or there may be subdivisions, different types of MG. They're still working on it. But just as a reminder, here's the end of our axon, our nerve cell, and it comes down, and there may be a muscle here on this end. When this nervous signal comes down to the foot process, these vacuoles containing acetylcholine move to this cell membrane. They open up, they release the acetylcholine. The acetylcholine serves as the chemical transmitter that transmits the nerve cell to the muscle cell, which is down here. So this acetylcholine, which is, I talk about the action potential as being the go signal in nerve transmission. So this action potential comes down. That's an electrical type signal. It's converted to a chemical signal via this acetylcholine, which rapidly drifts across this cleft. Now this cleft is infinitesimally small between the nerve and the muscle. And it comes across, and in order to then take that message to the muscle, it has to bind to the acetylcholine receptor, which then opens the sodium channels, and then we end up with muscle contraction. But in people with MG, they have these autoantibodies that block this receptor, so acetylcholine is released into the synapse, but it can't get to the receptors, and so it disrupts the transmission of this signal. Goodpasture syndrome is an autoimmune disorder in which patients produce autoantibodies to the basement membranes lining the renal glomeruli and the lungs. These antibodies that bind lead to the formation of the immune complexes that then attract complement, and then we end up with a type 2 hypersensitivity reaction. This syndrome can progress to renal failure and respiratory problems, and there are certain antibodies to glomerular basement membrane that are found in most patients with Goodpasture syndrome, and there's a couple of different ways to detect these, including direct immunofluorescence. To summarize some of the major concepts from this unit, we've learned that autoimmunity results from loss of either central tolerance and or peripheral tolerance. Environmental factors play a key role in the development, things like infections, tissue injury, exposure to environmental toxins, etc. These trigger autoimmune disease in individuals that are genetically susceptible. The fact that there's a genetic component to this relates to the fact that if people in your family have autoimmune disorders, you are much more likely to have an autoimmune disorder, as well as the fact that any given individual with one autoimmune disorder is more prone to develop additional autoimmune disorders. The systemic autoimmune diseases that we looked at include systemic lupus erythematosus, or lupus, and rheumatoid arthritis. Most patients with rheumatic autoimmune diseases such as lupus produce ANAs, anti-nuclear antibodies. ANA testing is often done with fluorescence testing, and when we use fluorescence, we're looking for the pattern of fluorescence, and the patterns include homogeneous, peripheral, speckled, nucleolar, and centromere. Some of these patterns are fairly specific to a given illness, but none of them are totally specific, and so there's a lot of overlap in patterns and illnesses. Often titer is an important clue for the doctor. A low titer ANA, for example, may not help in the diagnosis of some of these things because we can see these lower titers in individuals with other disorders. The rheumatoid factor, or RF, is an autoantibody directed against the FC portion of IgG. It's found in most RA patients. However, it too is not totally specific, and it is often found in patients with other types of autoimmune diseases. We looked at several organ-specific autoimmune diseases and their characteristic autoantibodies. Now, this list that follows is probably what you want to focus your studying on as far as the antibodies, because these are the main ones. So whether you want to make flashcards or a chart or what have you, that might be a good plan of action. In autoimmune hepatitis, they typically have antibody to smooth muscle, or SMA, smooth muscle antibody. Celiac disease, there's a number of potential screening autoantibodies, but right now it looks like the tissue transglutaminase is most specific for celiac because nearly everyone with celiac disease does have that one. In Goodpasture's syndrome, we look for glomerular basement membrane antibody, or GBM. Graves' disease, thyroid stimulating hormone receptor antibodies. Hashimoto's thyroiditis, thyroid peroxidase, which is TPO, and thyroglobulin, which is TG. MS, the myelin basic protein, or MBP. In myasthenia gravis, acetylcholine receptor antibodies. Primary biliary cirrhosis, mitochondrial antibodies. And type 1 diabetes, antibodies to the pancreatic islet cells, ILA2, and glutamic acid decarboxylase. And that brings us to the end. And since we've just been having some alphabet soup, maybe it's time for you to go make yourself a nice warm cup of comforting soup as you work on committing these to memory. Bye-bye.